Infant oral health care and concept of dental home. Hi there. Just yesterday I bumped into my old friend Dia, who joyfully shared news of her pregnancy. Inquiring about her well-being as a dentist, I also inquired about her oral health. To my surprise, Dia appeared puzzled by the suggestion of visiting a dentist, highlighting a common oversight among expectant mothers regarding the importance of oral health in pregnancy. Maternal oral health greatly influences the child's oral health, and prior knowledge about oral hygiene and feeding practices can prevent the development of oral diseases. Did you know? The perinatal period is the period beginning with the completion of the 20th to 28th week of gestation and ending 1 to 4 weeks after birth. And the period of infancy starts at birth and lasts till the first year. Wait, there's more. But before we go further down the rabbit hole, subscribe to our channel. Dia's interest in the impact of oral health on pregnancy led her to start researching, where she discovered pregnancy does not cause any oral problems, but may worsen the existing ones. It is a vulnerable period for the development of dental caries and periodontal problems due to fluctuating hormones and changes in the eating pattern. The mother is the first source of bacterial transmission in a child, and increased caries risk in the mother makes the infant prone to it too. Various research has shown links between periodontal disease and adverse outcomes in pregnancy, including preterm deliveries, low birth weight babies, and preeclampsia. Therefore, perinatal dental counseling of an expectant mother is vital and emphasizes five important aspects. First, oral health education during pregnancy is crucial for self care and future child care. Second, it acknowledges the potential transmission of karyogenic bacteria from parents to infants. Third, it involves assessing caries risk in expectant mothers to facilitate preventive strategies, including managing sugar consumption, brushing with fluoridated toothpaste, and considering the safety and efficacy of optimally fluoridated community water. Apart from this, it provides information on safe medications during pregnancy and lactation, common oral conditions in newborns and infants, non nutritive oral habits like digit sucking or pacifier use, teething, growth and development, and orofacial trauma. Fourth, it includes periodic and comprehensive oral examinations to reduce karyogenic bacterial colonization in the mother and address any issues present. Finally, it introduces the concept of establishing a dental home for the infant. Dia found herself puzzled once more when introduced to the unfamiliar term dental home. Did you know? The dental home concept stems from the American Academy of Pediatrics' medical home idea, where a child forms a healthy relationship with their pediatrician at an early age. AAPD's definition for a dental home is it is the ongoing relationship between the dentist and the patient, inclusive of all aspects of oral health care, delivered in a comprehensive, continuously accessible, coordinated, and family centered way. A dental home is an early introduction of the child to dental care, similar to visiting a pediatrician for a routine checkup. Dentophobia, or fear of dentists, ranks second among various phobias. Therefore, familiarizing parents and children with dentists through regular visits reduces anxiety about dental visits and helps prevent dental issues, especially early childhood caries, which can cause pain, hinder growth, and require costly treatments. The dental home aims at two important aspects. The first one is the visit at age 1. As recommended by AAPD, this is done ideally when the first tooth erupts. This establishes a dental home as part of the child's healthcare experience. The second aim is to provide anticipatory guidance to the parents, which has been defined by the AAPD as the process to provide practical, developmentally appropriate information about the children's health to prepare parents for significant physical, emotional, and physiological milestones. This is a new approach in dentistry, focusing on growth, development, caries prevention, and overall oral health of a child. Personalized procedures in anticipatory guidance from about 6 months to 2 years include oral examination, prophylaxis, diet analysis, home care instructions, fluoride application, feeding guidance. The next query Dia had was, how do I choose the dental home for my child? An ideal dental home has to be accessible, family centered, continuous, comprehensive, coordinated, compassionate, and culturally competent. Let us now get into the details of what each term represents. The term accessible denotes that the selection of a clinic should be based on its community presence, accessibility for 24/7 emergency care, acceptance of all insurance with seamless payment processes, and availability of multilingual staff. A family centered clinic is one that prioritizes a family centered approach, demonstrates care for both the child and parent, offers support for education and community services, and implements comfortable care protocols including behavior management strategies. Consistent dental care is primary care that is provided from infancy through adolescence. The word comprehensive denotes that the clinic should offer primary, secondary, and tertiary care, handle emergencies like traumatic injuries, provide impartial treatment for special needs children, and collaborate with medical facilities for complex procedures. They must also provide referrals to specialists when required. Apart from all these requirements, the dentist should be knowledgeable about preventive programs in the community, ensure continuity of care through tailored recall intervals, educate parents on home care responsibilities. The word coordinate means the clinic provides a smooth transition to school or other locations and facilitates unbiased sharing of information regularly that has centralized access. The term compassionate and culturally competent denotes that the dental home should provide comfort for both child and parent during any dental emergency or an issue, while respecting the child's cultural background. Dia was now fully aware of the characteristics of an ideal dental home. The next thing she researched was the main aspects of infant oral health care. The first thing she read about was oral health risk assessment. This should be done within 6 months, evaluating soft and hard tissue diseases, providing oral health education, and optimizing fluoride exposure. Next was the establishment of a dental home, where guidance on handling oral problems during infancy needs to be addressed. Guidance is essential during the teething period, as it can be challenging for both children and parents. Teething may cause localized discomfort, irritability, and increased salivation as primary teeth erupt, while some children may experience no issues. The treatment options for symptoms include oral analgesics and chilled rings for the child to chew on. Over the counter teething gels or topical anesthetics can cause potential toxicity in infants and should be avoided. Moving on to the most unexplored and important aspect of children, the oral hygiene. When should we start brushing in an infant? It should start when the first tooth appears. Cleaning the infant's teeth with a soft brush twice a day upon eruption helps reduce bacteria. Next is the dietary counseling. New mothers often grapple with the decision between breastfeeding and bottle feeding, pondering which option is superior and how long and how frequently they should continue each method. Human milk and breastfeeding offers numerous health benefits, reduce the risk of various diseases, and provide nutrition for infants. The glorious part is that it is not linked to tooth decay. On the other hand, frequent nighttime bottle feeding with bovine milk or formula may be associated with early childhood caries. Although breastfeeding more than 7 times daily and nocturnal ad libitum or on demand after the first tooth erupts can increase the risk of early childhood caries. Exclusive breastfeeding for 6 months and the addition of iron rich solids between 6 to 12 months is a recommended regimen. AAPD suggests infants take liquids from a cup as they approach their first birthday and be weaned off the bottle by 12 to 14 months. And lastly, nighttime bottle feeding with juice or sugary drinks and consuming sugary snacks between meals is also known to raise the risk of cavities. Moving on to fluoride exposure. Optimal fluoride exposure is crucial for infants and children's dental health. Decisions on fluoride use should be tailored to each individual's needs, with a focus on preventing dental issues while minimizing the risk of mild fluorosis. For children under 2 at moderate or high caries risk, a smear of fluoridated toothpaste is recommended, while children aged 2 to 5 should use a pea sized amount. Professional fluoride treatments like varnish are beneficial for those at risk for cavities. Systemic fluoride may be necessary for children with low fluoride water intake after considering dietary sources. Monitoring fluoride intake is important to prevent fluorosis linked to enamel development. And the last aspect addressed is injury prevention. A practitioner should provide age appropriate injury prevention counseling for orofacial trauma with play objects, pacifiers, car seats, and electrical wires. Pop quiz. Dia's recent research on perinatal and infant care will help her be a well educated mother. We hope you enjoyed this video too. Join the learning community with our app and website now.